guys. We are here with Jess, who is going to be telling us about how she got into teaching and becoming a professor at a PTA program while also being a PTA, and how she did it, and some of the things just about being a professor, and was that something she always wanted to do. So we are going to dive into an interview with her. This is part 1 of 2. We've been enjoying so many of our interviews lately that we end up just chit-chatting and talking for a longer period of time of just everything about their experience and soaking it all in. So this is one of those episodes where we all of a sudden look down at the timer and we're like, oh wow, we're going pretty long. We're going to split this up. So let's go ahead and get into part 1 with the interview with Jess, and she can start explaining her story a little bit more. So let's go.
You're listening to the PT Assistants Podcast with your hosts, Ken
and Laura. Thanks for joining for another exciting episode. All right, guys, we are back. And like we said, we have a very special guest with us today. We have Jess joining us today to I'll let her just kind of share her story, but about how she kind of got into education and a little bit more as we go through it. But Jess, why don't you go ahead and tell us a little bit about yourself, like how long have you been in the field, what you're currently doing, and just like a little bit about your hobbies and stuff.
Yeah, absolutely. Well, first, thanks for having me.
No, thank you.
So I am a PTA by trade, I suppose, and I've been one for about 14 years. And I did that full time for about 9 years in some different settings. And so now I am in higher education and a PTA program. I've been there for 5 years. So that's kind of where my 14 years adds up there. Yeah. I still work awesome. PRN also. So I haven't completely left the clinic.
Fair. I love that. I actually, like, right off the bat, I love the fact that you stayed in the field, because I feel like it's so important. Because there's been, I've worked with some professors before, and they're out of the field and they don't have the touch of like what's actually happening. So I think that's so cool that you decided to stay in the field and everything. Yeah,
I feel like, how can I stand in front of students saying, this is how you do physical therapy, if I don't do physical therapy? So yeah, that was important to me.
Yeah, it's definitely a big part of it. As far as the settings you've worked in, do you have a favorite that you worked in, or one that you spent most of your time in? Certain patients you like a certain population you like to work with?
Sure. So I've done a lot. I would say most of my time was spent in outpatient.
Yeah.
Full outpatient.
However, I will say, clearly, and I can't. It was either that or home health. So I've never worked in like inpatient or acute care. Mm-hmm. So I did home health as well. But my first outpatient job actually was pediatric outpatient, which, as you all probably know, at least in PTA school, like little to no training on pediatrics. So that was very much a on-the-job learning. But since, for the last 5 to 7 years, my job's been in outpatient orthopedics.
That's awesome.
Very nice. Very nice.
I again, you might be a little biased here. I've tried a couple of them here and there. Plus I did grow up kind of seeing home health a little bit. My mom had a couple side jobs here and there because my mom was also a PTA, and she worked with the patients so long that, we'd come tag along on occasion. So
sure.
Literally, I think she had one patient that, he was going to get, home health for the rest of his life, as long as he wanted, because doctor screwed up and hit the brain stem. And so he was, paralyzed. So there was a lawsuit. So medical was all covered. So my mom had worked with that family for like over 5 years. And so we got to go in and see a lot. So I've seen quite a few different fields, but I will say I do drift back to the ortho. It's just, I like it. But again, nothing bad against the other settings.
Sure. No, there's a place for everyone in physical therapy. There's so many opportunities that you'll find somewhere that works.
Right. Any side hobbies or things you like to do when you're not either, I'm sure, grading or working?
Right, all the extra school stuff.
All the extras. Of course. I'm a big reader, but even that, there's no genre I specifically like. I just like to read. I'm a runner. I use that word very loosely. I used
like,
to
you
be
enjoy
definitely.
running?
I used to. Got out of it, tried to get back in it, and realized, oh, this is hard. So sometimes I run, but more what I do actually, I'm actually going to head out west next week on Monday. My sister lives in Arizona, and I'm going on a hiking and backpacking trip. So I like to spend time outdoors.
They
awesome.
definitely have some good ones out in Arizona.
Yeah.
And right now the weather's warming up a little bit out here in our desert area, so Arizona kind of usually follows that too. So shouldn't be too bad.
Yeah,
Be too
the
cold.
weather's looking okay.
Yeah. You never know. I know I never got the whole running thing, even when I was like a competitive athlete. Like, so I swam competitively for when I was 5.5 all the way through college.
Oh, wow.
Even then, I hated running. I do everything to get out of it. I never understood that concept.
Yeah.
Like,
I was gonna say, we have a patient right now. She's about to run a marathon, and I'm just looking at her. I'm like, I don't know how in the world you're gonna do, like, that's just so much running. I'm like, do you actually enjoy it? And she's like, nope, I hate it. I'm like, and you're gonna do a marathon. Let me know how that goes.
I mean, if you love it, okay. That's one thing. But.
Right?
yeah, I willpower to them. I'll give it. There's a lot of willpower to you guys who get just let me go out and run. Yeah, no, I think a bear needs to be chasing me in order to run. Even then, it might be iffy. I might just
That'd be
look at
questionable.
it.
You might just you're gonna do the play dead route.
Good.
I'm good. The bear seems more tolerable than running. But all right, so we'll go ahead and get into a little bit more of like, how did you transition from working full time as a PTA into education? Because that's something I've always kind of been a little interested in. Maybe down the line is going into that field. Well, not that field, but that
part of
track.
the field.
There we go.
Yeah.
Honestly,
I kind of lucked into it, I would say. I actually, when I was doing one of my home health jobs, my immediate supervisor was a PTA in that position. I think that was the first time that I'd seen kind of a PTA being in some sort of managerial or administrative role. Mm-hmm. And so I remember thinking like, okay, like there's a ladder to climb somewhere. Like I don't have to just treat patients forever if I don't want to. Mm-hmm. So after a few years, many years of treating full time, I went back to go get my master's degree and got that in healthcare administration. And I figured with that one, I could either, again, do management at, home health or outpatient or maybe some sort of hospital administrator. I wasn't really sure. It wasn't actually until later that I realized that I could also use that master's degree to go into education. And I'd been a CI, I'd been a clinical instructor basically since the time that I graduated, and so I'd made some contacts with local schools that way also. And I actually reached out to one of our local PTA schools and said, "Hey, so I'm working on getting my master's. What do you know? Like, what's out there? What can I do with this?" And again, this is how I looked into it. She said, "Oh, well, actually, we just had one of our faculty members put in their notice and is quitting.
You're like,
would you be interested?"
What great timing.
I know, yeah. So couldn't have been better timing. So that's kind of again how I lucked into it. Didn't know if I would like education. Again, that wasn't my initial thought when I was looking at getting a higher degree. But clearly I like it. I've been there for 5 years, so it's good. But again, I lucked into it, and I think that the route of getting a master's degree opened up a lot of worlds, and that this is just kind of the one that I ended up in.
Now, to teach, do you have to have a master's degree?
I will be honest, I don't know what it's like state to state. So I know in my state, in order to be a full-time faculty member, in order to be credentialed, is the word they use to teach certain classes, I did have to. But one of the things I was going to bring up later was actually the fact that we have adjunct faculty, so somebody who comes in and helps run a lab, who's more than just a guest speaker, is there a little bit more regularly, but isn't full-time. And adjunct faculty do not have to have a master's degree.
I didn't know that. Because, just working with undergrad and that kind of stuff, I do know it differs from school to school, and each university has their own rules sometimes too. Like if you get into private, they won't require as much sometimes as, a state-funded one will.
That makes sense.
So I do know like it differs from each one, but I will say like most of the route they do require, from what I can tell, like a higher education. But I did not know that about adjuncts, that they're kind of more of like, you can teach, but since you're not working or you're not teaching full time, you don't have to have all that stuff.
Right,
So
it's
it's
like a
more
little
Yeah.
like you
gray
could do
area.
like a half and half.
Because I think you need a
Yeah. Well, and
certain.
that's
Oh, I was gonna say, like, I think for our school, because I had somebody tried to apply to be a professor there. Unfortunately, they didn't get it, but they said you had to have, like, I think 4 or 5 years minimum of experience in the field before you can apply.
right, which is
So I don't know if
crazy,
that was
but
the case for
makes
you,
sense.
or if you've heard of
I
any
don't,
sort of minimum
yeah.
requirements.
Now, if I had my job description in front of me, I could probably tell you better. Yeah, I do know that there was a minimum. Don't remember exactly what it was. There was a minimum of teaching or of treating, and
Hmm.
the recommended, if possible, to have some teaching experience, which of course clearly I didn't have going in initially, but yeah, some level of experience before teaching was required.
In a way, though, I feel like you could just take our job and say it's a teaching experience, because really, day to day, we are teaching patients on what's going on with them and why we're doing the things we're doing and how to do it properly and the best techniques to do it. So, like, I feel like you can kind of relate your actual in clinic experience with teaching experience. Like, I'm sure it's
On
different,
Absolutely.
top
don't
of
get me
being a
wrong,
CI as
but
well.
yeah.
Yeah, so well, to both of your points, yeah. So I mean, I think being a clinical instructor is great because you get to, I mean, you are literally teaching students,
Hmm.
um, and kind of you expose you to the academic world. But you're right, Laura. Like that's one of the notes that I actually, both of those notes, you guys checked both the boxes, but but clinical instructor is one, and the other one was we educate patients all day, every day,
Hmm.
and it's like you said, it's different, but it clearly correlates to being able to educate students. And I do remember actually when I first started teaching, I felt, you all know this, we learned things in school and we took tests on it, and then we got to the real world, and it wasn't always that
It went
way.
by.
Oh,
What?
Oh,
Yeah.
I thought mine left the door. If I don't use it, it's gone.
Yeah. Yeah. And so I remember when I first started teaching, I had to like reteach myself. So I'm like, I haven't thought or looked at some of this
some of these
stuff in
concepts.
years. Yeah. So I had to like reteach myself. And then I thought, well, as a teacher, I'm supposed to know all of the answers. So like if a
Mm.
student would ask a question and I didn't know the answer, I was like, I'm inept and I shouldn't be here and I have no idea what I'm doing.
The imposter syndrome set in.
Imposter syndrome.
Hmm.
It did, and it still does sometimes. But then
Mhm.
I realized my students are just like patients, right? They have questions, and if a patient were to ask me a question I didn't know the answer, I would probably be like, "Huh, good question. Let's look it up,"
That's a
and
good
we would learn
point.
together. And so I try to do the same thing with students now. So
There you go. Yeah, it is definitely funny when I thought the same thing. I was like, man, when Ken was going through school, he'd come and be like, start
Oh,
talking
this is
all
the
the
best
stuff
part.
and book stuff. And, and I'd look at him and I'm like, I don't know. I don't care. I don't use that
Yeah, I did that all the time. So when
all the time.
I was a
I was
tech,
like, you're
and
really making me
we had
feel
done a
dumb.
PTA, and I was like, "Oh, hey, what's the origin and insertion of this muscle?" And they're like, "Are you serious? I don't know." And I'm
I'm
like,
like,
"Really? You don't know this?" And
this
it's
region.
like around here. That's all I need to know.
this
It
area,
does these
yeah,
I was like,
actions. We're
it
good.
runs like this. It does this
I don't need to
action.
know. It's exactly
Do
the
I
third and
remember the
fourth rib. I don't need to
exact?
know all that.
nope,
No.
nope,
If I
yeah,
know the
it's
general region, the way it's running, we're good.
my default is now a student will be like, is the insertion of the biceps the radial tuberosity? I'll be like,
Look it up.
well, what do you
What do you
think
think?
it
That's
is?
I don't know. Ken
a
would
good way
always
to
look
do
at
it.
me and ask, and I'd be like, "You're really making me feel dumb right now." I was like, "You learn it for the test, and then there's things that you definitely learn to get past the test, and then I think the big thing is when you start working in the field so often, you start to speak in layman terms too.
Oh
And
yeah,
so you just naturally go that route too. So you certain things that the way they say it in the book and in school, like to me, I'm like I can explain it better in layman terms than actual medical terms
absolutely.
nowadays. And
Yeah.
I've been treating for about almost 6 years now.
Okay.
Um,
Well, and
so
depending on what setting, you said it earlier, like if you use it or lose it, right? I mean, you
yeah.
guys aren't going to remember anything about
Oh, inpatient.
hemoglobin levels and whether a patient should do
Absolutely
it.
not.
I mean, I don't
I
actually
love
either.
the
But
great little red marks
I'm like, are
when
we
I
being
did
quizzed right now?
inpatient. I
well,
felt
'cause I don't know things.
Hemoglobin 14, maybe?
well, but the thing is it's funny though because like I think that, and then it was really funny going through my own surgery and everything. My husband came in for my very first appointment for physical therapy, which was with the PT I worked with at the time. Um, and so we go in the room and he's technically doing the eval because he still has to do the eval. We're going through insurance and everything. And so we're talking, and my husband's literally sitting there, and I'm thinking we're just talking like normal, right? And he goes, "You two are speaking another language right now." And I was like, I didn't even think it was that intense, but it's funny how like when you do get around to other people though too, like you do realize, hey, you know what you're talking about.
Oh yeah.
It is there. So I'm
Yeah,
sure.
I've been married for 15 years, and there are times where I'm still like, how do you not know this word that I've probably been using once a week? But then other times he'll bust out something about like shoulder flexion. I'm like, oh, he is learning things.
He's
So that's
listening.
great. Yeah,
I know more about my husband's job than he knows about mine.
fair.
That sounds about right.
Yeah.
But you've worked in his
But
world. He hasn't worked in yours.
this is true. I did take a little bit of time off between the foot and going back, and so I worked at home for a little bit. Didn't help, but made me love the job again. I will say that, which
Oh,
was
that's good.
nice. Yeah. But now, speaking of kind of like going in and not knowing everything, how did you prep for it? Like, how did you get back into like, hey, yeah, the book says this, but really, like, in clinic, that's not really
Oh,
how
yeah,
it's
that's a great
done. Like, how
question.
does that, like,
How do you battle
how did
that?
you do that?
There's a fine line, right? Because we all know, and even the students know, they have to pass a test at the end of this, and they need
Mm-hmm.
to know what the book says. But of course, we want to make them good students and good clinicians so that they know what to expect when they're going out on clinicals and then out into the real world. So I think I'd probably say like 95% of the time we say what the book says goes. This is how you should do things, unless there's just something that we know that the research is showing that that's not the case anymore. Because sometimes our books are, we try to keep the most up to date, but
Mm-hmm.
maybe they get updated every 5 years or something. And sometimes there's new research, so we'll say we know this is what the book says, but here's what we see
Yeah.
in actuality. And of course, the board exam also changes every few years, so it's constantly being updated with the newest and best evidence-based practice as well.
Yeah, it's definitely I feel like it's always so tough because I think when they sent us out on our clinical rotations, they said, you're going to learn a lot, and you're going to learn a lot that didn't seem like it was in the book or says opposite of the book. They're like, that's great. Use it, but not on your test.
Right. That's exactly right. So I've been at this school now for long enough. So I actually, in the last year and a half or so, am now the clinical coordinator. So I'm the person who's
Awesome.
sending the students out to their clinicals. And yes, we do a lot of those conversations as well. Of we know that when you go to clinic, it will be different, and that's okay.
Just put it in your back seat for later. You bring it forward when the passenger in the front gets out, aka at the test, after the test. Once that departs, you're good
Good
to go.
analogy. Yeah, I love
Yeah,
it.
I had a patient. So I graduated from school, and then before I took my test, I worked under a graduate license. And one of my patients, she was an instructor for the nursing program. And I was working with her, and I was telling her, I'm like, oh yeah, like I'm a graduate of physical therapy, but I take my test in a couple months. And the first thing she would like harp on, or like every visit, every time I worked on her, she'd be like, stop learning what you learned in the clinic. Always review your book. Always review your book. And she would just harp on it. And I'm like, yes, I
Yeah.
know. I have to go back to the books because you do pick up a lot of stuff in the clinic. And since I worked for 3 months straight before the test, I'm like, I can't use any, like, maybe I can think about it, but I can't reference it. Like, I have to think about what's in the book.
Right.
Mhm.
No, it
But it
was
was nice to
lucky
kind of go
lucky that
across
she
that.
was a patient. Yeah.
Yeah.
He was also around me. I kept yelling at him.
Good.
I was like,
I got
"This
it
won't be on your
done.
test." No, are you kidding? Ken, I told him right from the beginning. He'd ask me things, and I was like, "I don't know. You're smarter than me." Right off the
It's all
bat,
the book stuff.
Ken is really good with that stuff. I've got just a little more experience personally being always injured. So I've got that stuff under wraps. But I forgot, we never actually asked you which courses you teach.
That's what I was gonna
Oh
ask.
yeah, nice.
Have-
So at this point, I've taught everything in our program except the the intro to. We have like an intro course. I think most programs do. About what is a PTA, the legal, ethical kinds of things. I've not taught that. Pathophysiology is not my jam either. So lots, basically all the diseases of the systems of the body and how it pertains to physical therapy. And then we have our basic.
Now.
Right? Yeah. I mean, the big ones I can talk to you about, like diabetes.
Yeah. And then you get
like
those weird ones that
infarction.
we learn slightly, and then someone comes in, and you're like, I don't know.
It's like, you have what?
What?
What's that? I've heard of that before.
Like, we have a patient right now that has peripheral demyelinization. So a form, not not MS, but MS, but not MS. Like, it's the weirdest thing.
That's so demyelinating for an unknown.
Yeah, reason. But it's just only in the peripherals.
That is interesting.
Yeah, so it's very interesting. But I was like, I'm going to have to go back to the book now.
Yeah. Luckily, we get those patients every once in a while. It makes us think a little bit.
Yep, exactly. She's in there for her foot and everything, but it was like, okay. Like, my PT's like, do you remember this? And I was like, no, I don't.
No.
I was like, and she said the name, and I was like, so pretty much MS, but just in her peripherals. No. And she goes, yeah. And I was like, okay. Well, we can make that work. It's just weird. It's things like
this
that
would be, excuse me, advice that I would give to a student too would be like, okay, like the diagnosis might be interesting, but like, what are they presenting? Like, what are their goals? What are we going to do? Like, as long as it's not contraindicated, then technically does it matter what their diagnosis is, as long as we're working towards function.
I do feel like in school, it gets so focused sometimes on what the diagnosis is versus like what we actually want to gain and what they can do. Because, I've got a patient right now who's Parkinson's, and she's not in there for Parkinson's. She's in there for a post-op. And so, like, we can work on a couple of her Parkinson's stuff, but it's not Parkinson geared really therapy in a way. So, like, it's just interesting, like, to see, like, the difference being in school and out of school, but definitely fun. But
I wish that we actually did a bit more of talking about, I don't want to use the word comorbidity, but like dual diagnosis. So it's like someone who has Parkinson's who also has, I don't know, shoulder pain, who had a fall, something. Because we do a really good job, I think, of talking about like kind of siloing these individual diagnoses. But that's not real life world either. Yeah.
Yeah. No, and that's the tough part too. Is like, man, I've just got a lot of patients right now. I'm like, that are interesting. Like, we have a patient right now who came in for post-op lumbar surgery. Forgot exactly what he had, but he's had plenty of strokes, and really he should be more neuro. And our neuro clinic won't take him because they're like, well, he's there for ortho. And we're like, yes, but like, he's got so much other things going on cognitively. He's not all there. Like, he's a better candidate for neuro. And so it's like, the battle of it. And I feel like in school, it was the tough part just in general with the setup of like how they would separate things so much. And that's how you learned it. So sometimes like, I feel like that's not real life. And that's the tough part.
Yeah. I feel like for my program, I think the big one was like focusing on the diagnosis too much. So when we did a lot of practice, like in class, we would have like that practice patient and all that, and they would be treating each individual one. But I was like, you also have to think about what they enjoy doing, because if you want to keep their compliance up, you want them to keep coming and enjoy being there. Like, do they like to golf? Do they like to garden? Do they want to go back to playing a sport? Like, if you orient your treatment around that, they're more likely to come in and actually want to be more involved. And then the second one for me for the dual diagnosis, I have an MVA with knee pain, neck pain, back pain, but he also has seizures. We're doing nothing with the seizures, but now I have to keep in mind, like, making sure that the treatment stays mainly on the table. If we do any walking, I have to stay with him. Like, so making sure that there are multiple things you have to pay attention to.
Yeah. Absolutely. Might be an easy diagnosis just because it's
The MVA,
you know,
yeah, but the
MVA,
seizures plays
you're
a
like, oh, it's
huge
a lot of,
role into what I have to do as far as intervention
yeah.
wise. I can't just
Sure.
put them on a treadmill and do all that stuff.
Well,
It's just not a good idea.
So how would you like, since you're still treating, which again I think is so awesome. You know, you get to see out in the field what's still going on. And it's kind of like over the years how it's starting. At least out here, I feel like treatment is starting to change a little bit, get a little bit away from like the here's the set plans into again more individualized plans per patient. How do you kind of fit that into the program and with students, but at the same time make sure it's a guidance with what the book and everything? Because I feel like that would be the tough part, is not fully bringing in so much of your clinical experience.
right. No, that's a great question. So yes, as a PRN, I same thing here. I think we're starting to see a shift, but we're also teaching that in the program. So it's that
Mhm.
every patient is an individual, and I think kind of the last two comments that you both made go into it. So it should be an individualized plan based on what the patient wants to do. Right? We all know that function is the big word. What does the patient want to do? We'll work
Mhm.
towards doing that. And so in the classroom, yes, of course, we teach them what the book says, but even things like in our basic therapeutic exercise course, we go over some super basic exercises for every region of the body. But then we'll throw out, like, not just, here's 5 patients who have all had knee replacements. They are totally different people. One is 45 and it was
Oh, that's
traumatic. One
awesome.
was 65 and wants to do this. There's male, there's female, there's athletes, there's sedentary, desk job people. Like, so what does your plan look like for those? And they all, again, like acutely, we're all probably doing the same exercises with all 5 of those patients just to kind of get some blood flow, get some basic
Mhm.
strengthening back, doing some isometrics. But as their plan progresses, we're going to choose different
Yeah.
things for.
Like if you got an elderly woman who wants to get back to gardening, you're going to start doing some kneeling activities. Like,
Absolutely. Mm-hmm.
so yeah, like that is so awesome. I wish they had done that, because when I went to school, it's the same thing. Like, here's your patient, it's a set one. Pretty much you gave 3 exercises that were generalized and moved on.
Right.
And they didn't really
Same.
challenge us to think outside the box, which brings me to kind of my next topic, I guess, in a way of like, one of the things I wish I got lucky, because I was an athlete, gone through physical therapy since like I was in and out since I was 9 practically. My mom was a PTA. So like I grew up in the field. So I knew different types of exercises and progressing a little bit and that kind of stuff. But we had a lot of people who didn't. So we learned 3 exercises maybe for a body part and then you move on. I believe that there should be a full class just dedicated to full on exercises. Like nothing else but teaching you the proper way, because the thing too is like you get out in the field and someone might show you, but really in the long run they got taught it wrong. You got taught it wrong, and so it's this taught wrong exercise this whole entire
Vicious
time.
cycle.
Yeah. So like what's your thoughts on something like that? Do you feel like that would be beneficial in the program? Do you think that will ever be in a program?
I mean, I can certainly see the benefit to it. Like, now that I've been in education for this long, like, I don't know where we would
Mhm.
fit it in. Like, I don't know.
Yeah.
I don't know where we would find the time, honestly. So yeah, like, it would definitely be great because you're right. So our students feel boxed in is a good word. So my students actually went out to clinic today. So knock on wood, I didn't hear from anybody. I think
That's a
they're
good
all fine.
sign.
It's great.
No one's
All
Um,
right,
accused
that's a
of
good thing. No
no
one's
phone
asking
no
calls.
one
for
said
SOS and help, and
they put a you know.
Nothing crazy so far. Um, but yeah, so like we teach them the basics, right? Which is what we feel like we should do because we want them to use their imaginations. But
Mhm.
you're right, if they don't have a history and they don't even know how to use their imaginations to come up with something new, so then they get to clinic and their clinical instructor says, "So, what are you going to do for Joe here who had his knee replacement?" And they're going to say quad sets, long arc quads, and squats. And the CI's gonna be like, "Okay, anything else?" And the students be like, "No, I don't know
I
how
don't
to
know
use
that's
anything.
that's
I
what I
don't know
got.
anything else. That's all I got."
Yeah.
And so, like I try to teach my students that clinicals are a class. Going to clinic is not to show what you've learned and prove yourself. It's to
Mhm.
go and learn. So I think going to clinicals is where they'll hopefully, if it's a good
Learn a
clinical
lot.
site, get just tons of input about all the different ways people
Yeah.
can do things.
I think that also a little bit is just an experience. Like I finally feel like I'm just kind of like, as years have gone, I'm like, I'm just going to do this. I'm going to try it. Like we have with our Parkinson patient, she walks with a very narrow base of support. And so literally what I did the other day, and I was like, you know what, we're just going to try this. I took 2 cones, put them, set them up and said, all right, we're going to march, but you're going to land your feet with those cones and just match it. And I was like, it's not really technically an exercise, but what we're working for is for her to get that motor pattern going with that wider base of support. And so I think that's the hard part, is when you're fresh out of school, sometimes you do, like I ran to a CI where she had never had a student before. I was her very first one. She was a PT who was a year and a half out, older because she had changed careers, never worked with a PTA.
Yeah.
And it was the most stressful thing that I was about to quit school because, and like, even I had to talk to, luckily my clinical director for our program at the time, she was just absolutely amazing. Because she was just like, I know, I get it. Cause we talked about it going through, and she's like, they're not like this. They're not all like this. Like I've had to talk to her about it. Cause like she would just question me on everything, like joint mobs and things like that. And how do you deal with a situation like that where you've got a student who's like, it's not technically that they're doing anything wrong, but the person that they're working with just has too high of expectations for them in a way?
Yeah, no, I think that's a great question. And we've had, even just general, where the student and the clinical instructor they just don't mesh as people, right? They wouldn't be friends outside of physical therapy. We try to avoid that, of course, but yeah, I do. Well, it sounds like you had a great clinical director, because I do something very similar. I make sure, if a student comes to me with a concern, then I try to find a way to reach out to the clinical instructor without being like accusatory, not like you're doing it wrong. It's more like, here's some
tried this
research about what our program is like and the expectations of our students, or like, here's some tips and tricks on how to give feedback appropriately, so they try to be like subtle about it.
You're like, I'm giving these out to all
There's
of
some
them.
hints
Everyone is getting it.
Yeah. So and I hope that your situation, I've had it happen once, but I hope that those are few and far between. I'd like to think that clinical directors, kind of know what kind of position they're putting their students into.
Well, yeah, and it's tough when you got someone who's taking on new, and I knew it too, but it was just like, I was planning on taking originally the test early, but because of that, I was like, nope. I can't do this and try to study at the same time, because I was coming home feeling like I took a test every day.
Oh, yeah. Well, that's probably smart. That was a good decision then. It gave you more time.
So it definitely, like, it's like, I got, again, I'm lucky that my clinical instructor for our whole entire program, like she did an amazing job of like walking me through, like, it's not you, like, yes, technically you got not great reviews of like this, but she's like, I read over what your reviews are, and this is the things you're supposed to be being taught, so you shouldn't know these. So it was definitely
did you guys
interesting.
go to the same the same school?
We did.
But different times.
Right. Were your clinical classes pass fail? Do you know? Do you remember?
Yes.
Okay.
But we did get cool. Like a kind of like a grading of like excellent, average, or above average,
and then entry level and all that,
or something like
right.
that.
Yeah, all those. Like, so do you guys? So yeah, the CPI. It sounds like you're using CPI words. Yeah. Okay.
I was like, Ken was in school sooner than me. I'm like, I forgot that.
Yeah,
and honestly, I've been a clinical instructor so long that like we used to handwrite the CPI. So like we would have to like write in the box how the student was doing. Now there's this whole thing called the internet, and it's just amazing, and just type
right
stuff.
So convenient. I was gonna say, like, as far as like the exercise, kind of going back a little bit, but kind of recently graduating, and my PT would always ask me like if I needed help with anything. I think the biggest thing for me was figuring out when to appropriately progress a patient. So I was a technician before I went to the program. That's how I met Laura, for about 3-4 years. So I had this like foundation of so many different exercises for almost every single scenario. But I went to school, I graduated, I did all the things, and then when I became a PTA, it's like, well, I know how to address that issue, but my biggest problem was when. So
Sure.
should I just go for it and then see how they react? Should I do less reps? So I feel like that's where the experience really sets in, and like going to those clinical rotations is so important because you'll be able to see that firsthand. Okay, well, did they hit a criteria first? Like, oh, they did shoulder flexion all the way up. Let's go to active range of motion, things like that.
Right.
But I think for me, that was like the biggest hurdle, not having like some sort of exercise program in our schooling, because it's like, okay, let's do this, and then just tell me how you feel next time. So I think I got used to the whole experimenting with different exercises and just asking for a lot more feedback from patients was really big for me once I graduated.
I think you're exactly right too. It's not like some diagnoses come with a criterion. Like they have to be able to, like post-op, like they have to be able to bend this much before they can do X, Y, or Z. So that's kind of helps give us a guideline, but most of our patients aren't that way. So yeah, trying to figure out when is definitely a big question that all of my students ask. And again, clinicals are super helpful with that. But yeah, being able to communicate, like there's so much like go learn, memorize, and just know knowledge about all of the things. But at some point you need to be able to be personable and communicate with your patients to see
be able to apply
how
it
they're
all.
feeling, to be able to apply it right appropriately to these individual patients like we talked about earlier. It's going to be different for everyone.
Oh, I don't know why your progression story reminded me of Ken. Literally, like the first week I started working with Ken. It was my first job outside of school officially. And Ken was a technician, and it was both me and him. And I progressed a patient, and patient came back not feeling great, and it kind of felt a little worse. And I was like, oh my gosh, I'm getting fired. I don't know if you remember this. I gave him like bird dogs, and I was like, I'm going to get fired. It was nice knowing ya, like all this kind of stuff. And he's like, you're not going to get fired. And I was like, I am. I progressed the patient too soon. Like, I guess I'm going. And it's like, no, you're going to have those trials errors. And I'm sure you've even had students who probably come back and they're like, I think I did something wrong. I progressed them and they came back with more pain. Like, it's all the learning process.
We've all been there. Yeah, absolutely. I mean, so honestly, again, I've been doing this for a pretty long time, but being a PRN therapist is weird because I feel like I know things, but I'm essentially just usually covering for somebody who's sick or on vacation, and they're not really my patients. So I also don't want to progress them too quickly and have them be sore or mad at therapy as a whole. Like, I don't care if they're mad at me, but I don't want them to like stop coming back to therapy because it hurt too bad or something. So I find myself even now being a little bit hesitant on the progression train.
Or like you don't know the PT you're really working with on, like, is this something you're gonna do consistently or something like that? Yeah. No, I get that, because I was kind of filling in just after one of my surgeries, and I was like, we're just gonna do the same things today.
Right. And sometimes
just run
unless
it back.
it's like super like, oh yeah, you shouldn't be doing this anymore. Yes, it's way too easy. And I know, but it is definitely funny. Hey guys, this is Editing Laura coming through. That was the end of part 1. Again, this episode kind of ended up being a little longer as we were chit-chatting with Jess, and I hope you guys are enjoying it so far. We enjoyed it a lot, but this will end part 1. Don't forget to catch part 2 on Monday. Not Monday. Ooh, my days are completely off. This is what happens when I don't have Ken here to remind me what days we record and upload. But we will be releasing part 2 next week on Tuesday, so stay tuned for that. Again, it's amazing. All the information that she gives and advice has been absolutely so helpful and so cool to listen to. So don't forget to tune in, and then also stay updated on our Instagram and on our Twitter. And Instagrams are the most active, but we also have the YouTube channel. Again, we'll get some new stuff in. Life has kind of hit us a little hard lately, so give us a little bit of a breather on that. We'll get there though, guys. But again, hope you guys are enjoying part 1. Let's go ahead and we'll catch you next time in part 2.
The information in this video or podcast is not intended nor implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained in this video or podcast is for general information purposes only and does not replace your professors or a consultation from your own doctor or healthcare professional.